Now let's get started with the GIT radiology review. Look at the first image here. This is a normal barium swallow image, right? So this is the normal barium swallow image. You are seeing the barium opacified esophagus. And in this image, you are seeing a barium swallow showing a posterior midline outpouching. You can see this is a posterior midline outpouching. What is this called? This is your Zenker's diverticulum. Zenker's diverticulum. Now look at this barium swallow image. What do you see on this barium swallow image? On this barium swallow image, you can see there is a bird beak-like smooth tapering of the distal end of the esophagus. So such smooth rat tail-like appearance or bird beak-like appearance, this is suggestive of achalasia cardia. Achalasia cardia. Now look at this barium swallow image. Here you see this irregular shouldering and rat tailing like appearance of the esophagus. So if you see such irregular shouldering, right, and rat tailing, this is suggestive of CA esophagus. This is CA esophagus. And this is easy corkscrew appearance of esophagus. This is diffuse esophageal spasm. Now look at this barium swallow image. Here you can see there are thin horizontal mucosal folds, especially in the distal end of esophagus, and these are transient. They come and go away, especially in the distal esophagus in people with gastric esophageal reflux disease, and this is called as feline esophagus. Feline esophagus. And this is seen in GERD patients. But instead, if you have a young male with asthma or any atopy showing multiple concentric rings, as you can see in this image, in the mid-esophagus with narrowing and strictures, right, giving a pseudotrachea appearance of the esophagus. This is suggestive of eosinophilic esophagitis. So, feline esophagus is transient, thin horizontal folds which are in the distal end of esophagus, seen in gastric esophageal reflux disease, whereas eosinophilic esophagitis show narrowing and strictures in the mid-esophagus showing multiple concentric rings, seen in patients with eosinophilic esophagitis. So, feline esophagus is different, eosinophilic esophagitis is different. Feline esophagus is seen in gastroesophageal reflux disease that are transient mucosal folds, whereas the eosinophilic esophagitis, you have actual narrowing, constrictions giving a pseudotrachea appearance, and this will be associated with atopy in your patients. So, please differentiate feline esophagus and eosinophilic esophagitis. If you are having an immunocompromised individual with odynophagia, irregular mucosal ulcers giving a shaggy esophagus, this is suggestive of candida esophagitis. And if you see large discrete ulcers in AIDS patients, this is CMV esophagitis. Now look at this barium study. It is showing a concentric filling defect, and on CT scan you may see in this lesion multiple calcifications also. So if you see concentric filling defect in the esophagus with calcifications, think of leiomyoma of the esophagus. And where do you see such worm-like filling defects in the esophagus? That serpiginous worm-like filling defects. So remember, such worm-like filling defects, these are suggestive of esophageal varices, right? So worm-like filling defect or serpiginous filling defects that you are seeing in the esophagus, think of esophageal varices. And look at these chest radiographs and the barium studies that are given to you. You can see on a barium swallow, you can see the part of the barium entering into the trachea and the bronchi. And here on this chest radiograph, you are seeing that there is coiling of nasogastric tube. These are suggestive of tracheoesophageal fistula. Tracheoesophageal fistula shows coiling of nasogastric tube, and if you give barium, the barium may enter into the trachea and the bronchi. So this is tracheoesophageal fistula. Now look at these images. Here you can see a retrocardiac air fluid level. You can see part of the stomach herniating through the diaphragm into the thorax. So when the stomach herniates and enters into the thoracic region through the esophageal opening, here you have a retrocardiac air fluid level on the chest X-ray. So when you have the retrocardiac air fluid level on chest X-ray, please think of hiatal hernia or the sliding hernia. And what is the investigation of choice for hiatal hernia or sliding hernia? Please remember the investigation of choice is CT with oral contrast. CT with oral contrast. If you see a dilated esophagus, a dilated patulous aperistaltic esophagus. So when you see a dilated patulous aperistaltic esophagus, and also you see soft tissue calcinosis, and on the lung fields you are seeing bilateral reticular opacity, suggestive of pulmonary fibrosis. Right, on the chest X-ray you are seeing bibasal reticulations. All of this is suggestive of systemic sclerosis or scleroderma. So these are all findings that you see with scleroderma. Right. Now, what is this image showing you? In this image, you can see this is the stomach and this is the duodenum, the C-shaped loop of duodenum that you are seeing. So, when you can see the stomach and the duodenum, this is a barium meal. And look at this barium study. What do you see here? You can see these are the jejunal loops and these are the ileal loops. And this study is called as barium meal follow through when you see the jejunum and the ileal loops. And how do we differentiate jejunum and ileum loops? Remember, the jejunum has feathery appearance. This has feathery appearance. The reason we have a feathery appearance in the jejunum is because of this circular mucosal folds that run through and through the bowel wall. These are your volvulae conniventes or plica circularis. Volvulae conniventes or plica circularis. That is the reason you have a feathery appearance in the jejunal loops. And ileal loops, they are featureless. The ileal loops are featureless. Now, please look at this image. This image is showing a ulcer, gastric ulcer, showing a Hampton's line or ulcer collar. Hampton's line or ulcer collar, this is suggestive of a benign gastric ulcer. So, in benign gastric ulcer, when you have the ulcer, the mucosal rugae reach till the ulcer base. They reach till the ulcer base. And when you see a lateral view, you see the outpouching and you see the mucosal rugae coming till the ulcer base, giving a ulcer collar or a Hampton's line. So, Hampton's line or ulcer collar, these are suggestive of benign gastric ulcer. In benign gastric ulcer, the mucosal rugae reach till the ulcer base. Now, look at this barium meal study. On this barium meal study, you see a crescentric or a meniscus-like filling defect. So, when you see such meniscus-like filling defect, this is called as Karman meniscus sign. So, you have an ulcer crater filled with barium and the lumen filled with barium, and between you are seeing this crescentric filling defect. This is Karman meniscus sign, and Karman meniscus sign is suggestive of a malignant gastric ulcer. You can remember M for M, the meniscus sign on a barium meal is seen with malignant gastric ulcer. So, in malignant gastric ulcer, there is a mass and there is a central necrosis. So, the barium will come into that central ulcer crater and the rugae do not reach till the ulcer base. The rugae do not reach till the ulcer base. This is the ulcer and this is the mass that you have. So, they do not reach till the ulcer base in case of malignant gastric ulcer. So, when you see in the lateral view, so you see this is a mass that is there and this is the ulcer crater. You see the filling of barium here, you see the filling of barium here, and you see this Karman meniscus sign in malignant gastric ulcer. Let's try to understand this condition which is seen in 3 to 4 week old infant who is dehydrated, hungry and shows like olive-like mass in the epigastrium. And what are you thinking of? Yes, that is your idiopathic hypertrophic pyloric stenosis. And idiopathic hypertrophic pyloric stenosis, then the pyloric muscle is thickened and the lumen is narrowed. So, this thick pyloric muscle that will give you a cervix sign and a target sign on a short axis view on the ultrasound. So, the investigation of choice is ultrasound. The thick pyloric muscle will give you the cervix sign as well as the target sign. Idiopathic hypertrophic pyloric stenosis on the barium study shows you the first part of the duodenum showing this indentation appearing like a mushroom sign, and the thin column of barium between the thick pylorus, this appears like a string sign. So you see the string sign and the mushroom sign in idiopathic hypertrophic pyloric stenosis. In idiopathic hypertrophic pyloric stenosis, on an abdominal radiograph, you see a single bubble, that single bubble of the dilated stomach. Because of the pyloric hypertrophy, the stomach bubble will be seen. This is a single bubble that you are seeing. And in hypertrophic pyloric stenosis, there is gastric hyperperistalsis that is called as a caterpillar sign. And because there is gastric hyperperistalsis, the caterpillar sign, there is repeated vomiting and there is decreased gastric residue. In idiopathic hypertrophic pyloric stenosis, there is decreased gastric residue. And do remember the metabolic abnormality in idiopathic hypertrophic pyloric stenosis. You have hypokalemic, hypochloremic, metabolic alkalosis with paradoxical aciduria. So remember this important electrolyte imbalance that occurs in idiopathic hypertrophic pyloric stenosis: hypokalemic, hypochloremic, metabolic alkalosis with paradoxical aciduria. You can see this image again. What is this image showing you? This is jejunal loops and the ileal loops. This is barium meal follow through, and you can see the jejunal loops having a feathery appearance because of the volvulae conjuventis or plica circularis. These are seen in jejunal loops, whereas ileum appears featureless, right? So ileum is featureless and jejunum shows that volvulae conjuventis. So you should be able to differentiate the barium meal follow through image from the other imaging of the small bowel loops. Here you can see there is a nasojejunal tube, NJ tube, that is used. So when you use a NJ tube and you enter the jejunum across the ligament of Treats, when you enter into the jejunum and you do a double contrast study, you give a methyl cellulose which will distend the bowel, and also you give barium which will coat the mucosa. This is what is enteroclysis. So enteroclysis can be done by CT method, also called as CT enteroclysis. You are able to see the mucosal rugae better because of the distension of the bowel. Here also you can see the bowel with the mucosal rugae seen nicely. This is your MR enteroclysis. This is the T1 weighted MRI. This is the T2 weighted MRI. Remember, the fluid appears white on T2 and the fluid appears dark on T1, and the bones are black on MRI. The bones are white on CT. So you can see the pelvic bones, it's appearing white on CT, and the pelvic bones are dark. This is MRI. So you should know whether it is a enteroclysis given, a CT enteroclysis given, or a MR enteroclysis given, and differentiate enteroclysis from the barium meal follow through study. In enteroclysis, we use NJ tube, nasojejunal tube. Now, what is this abdominal radiograph showing? This is showing multiple oval, smooth, circumscribed opacities, which are, this is a patient who is brought with agitation or who is brought with abdominal pain or, by the officials in the airport. And when you're taking a radiograph, you are seeing this oval shape, circumscribed opacities in the abdominal radiograph. You should suspect the presence of these drug smugglers who are having these latex particles filled with drugs, right, kept inside their bowel loops. So this is what are called as body packers. So this image is of a body packer. Next, this is barium enema image. You know the barium enema, you should identify which is the rectum, the sigmoid colon, the descending colon, the transverse colon, the ascending colon, right, and the cecum. So these are the different parts of the large bowel. So this large bowel study is called as barium enema. And remember, barium enema is a high radiation procedure compared to barium meal follow through, barium swallow. The barium enema is a high radiation procedure. Now, look at this barium enema image. On what do you see on this barium enema image? On this barium enema image, you can see there is a dilated proximal large bowel and a constricted distal bowel. So when you see a dilated part proximally and a distal part in a newborn who is having inability to pass the meconium, think of Hirschsprung's disease. Hirschsprung's disease is basically colonic aganglionosis. So failure of migration of neural crest cells to the rectum, and this is commonly seen associated with Down syndrome. And remember, the dilated part is the normal part. The constricted part is the affected part. And rectum is always involved, right? Rectum is always involved. This is Hirschsprung's disease, also called as colonic aganglionosis. And remember, normally the rectosigmoid ratio should be more than 1. The rectum should be of more caliber, the diameter of the rectum should be more compared to the sigmoid colon. This is normal. But look here on these images, the rectum is constricted, the sigmoid colon diameter is more compared to the rectum. The rectum is constricted, the sigmoid colon is dilated. So there is the rectosigmoid ratio is less than 1. The denominator is more and the rectum is constricted. So the ratio is less than 1. So when the ratio is less than 1, this also should make you think of Hirschsprung's disease. Hirschsprung's disease. The rectosigmoid ratio normally is more than 1, but if it is less than 1, that is Hirschsprung's disease. This is congenital diaphragmatic hernia, where you see the bowel loops herniating into the hemithorax, compressing the mediastinal structures, the lung on that side. The most common type of congenital diaphragmatic hernia is this left posterolateral defect. This left posterolateral defect, where the bowel loops enter into the hemithorax, in the left hemithorax, causing left lung hypoplasia, that is mediastinal shift to the right side. All of this is suggestive of Bogdale's hernia. And Bogdale's hernia is more common. Bogdale's hernia is more common. But if you see herniation of bowel loops on the right anteromedial side, this is what is called as Morgagnes. Morgagnes is right anteromedial. Remember, right anteromedial is Morgagnes and left posterolateral is Bogdale's hernia, and the more common is Bogdale's congenital diaphragmatic hernia. In this image, you have a patient who is having epigastric pain, retching without vomiting, and also unable to pass the nasogastric tube. So when you have this classic triad, and you are seeing on the abdominal radiograph a coffee bean-like appearance in the epigastric region, this is suggestive of gastric volvulus. Gastric volvulus. So don't write it as sigmoid volvulus and come. If you are seeing the coffee bean-like appearance in the epigastric region with this classic triad, what do you call this triad? Epigastric pain, inability to pass the nasogastric tube, and retching without vomiting. This is called as Bouchard's triad. Bouchard's triad. This is suggestive of gastric volvulus. And what do you see on this coronal CT scan image? On this CT scan image, from a young female with emotional problems and chronic abdominal pain, you can see a distended stomach with lot of mottled air lucencies inside. And because of the emotional problems, young female, you should suspect the trichobezoar. So this is trichobezoar. There is distended abdomen, air pockets within the abdominal cavity, in the stomach cavity. This is trichobezoar, also called as Rapunzel syndrome. Rapunzel syndrome. Right? And what is this? Where you have abdominal pain in a post-operative patient at the incision site. So at the post-operative incision site, you are seeing abdominal pain, and the CT scan is showing a well encapsulated lesion with lot of air pockets within and some radiopaque fibers inside. So when you see such radiopaque fibers, the mottled air trapped within and a pseudocapsule around it, this is making you think of gossipyboma. That's a gauze piece that is left behind at the post-operative site. So gossipyboma. Also keep this image in the differentials. Gossipyboma, please remember this image, important in the post-operative patients. And where do you see single bubble on the abdominal radiograph? Single bubble is suggestive of idiopathic hypertrophic pyloric stenosis. And double bubble, where you see a stomach bubble and the duodenum a part of the first part of duodenum. This is called as a double bubble appearance on abdominal radiograph. Double bubble is seen in LAD, that is LAD bands, annular pancreas, and duodenal atresia. So they can produce double bubble appearance, and double bubble, this can be seen in the duodenal atresia, can be seen in Down syndrome, right? Associated with Down syndrome, you can see duodenal atresia. So remember the LAD bands. With that, you can remember what are the causes of double bubble: the LAD bands, the annular pancreas, and the duodenal atresia. And if you see part of the stomach, the duodenum, and part of the jejunum, this is jejunal atresia. This is triple bubble appearance. This is jejunal atresia. So single bubble is idiopathic hypertrophic pelvic stenosis, double bubble is duodenal atresia, triple bubble is jejunal atresia. And if you see multiple air fluid levels and a microcolon, so microcolon and multiple air fluid levels, this is suggestive of ileal atresia. Ileal atresia. Now look at this abdominal radiograph. On this abdominal radiograph, you can see that there is this distended bubble showing two loops and having a cleft in between, giving a coffee bean like appearance. A coffee bean like appearance in an elderly female with neurological symptoms. You should think of sigmoid volvulus. You are seeing a coffee bean appearance. This is sigmoid volvulus. And sigmoid volvulus will have the coffee bean appearance, also called bent tire or omega like appearance. And this loops, they extend from the left iliac fossa till the right upper quadrant, overlaying the liver. There is liver overlay. There is liver overlay sign. There will be the apex is overlapping the liver. So there is a liver overlay sign. And how to differentiate a sigmoid volvulus from a cecal volvulus is important. Sigmoid volvulus is seen in elderly patients with neurological symptoms. And you see presence of two loops without any hostrations. There are no hostrations. Remember, sigmoid colon is lesser caliber compared to cecum. So when this twists and this distance, the hostrations are lost. And in front of sigmoid colon, you have the large bowel. So it will be associated with large bowel obstruction. So sigmoid volvulus will show you this coffee bean appearance, bent tire or omega like appearance, usually seen in elderly patients with neurological symptoms. And the appearance will show you two loops with no hostration and associated large bowel obstruction. Also remember, in sigmoid volvulus, when you do a barium enema, you see a bird beak like tapering on the barium enema. So be careful. Bird beak appearance, also called as bird of prey appearance on the barium enema, this is feature of sigmoid volvulus. Sigmoid volvulus. Bird beak appearance on barium swallow is achalasia. Bird beak appearance on barium enema is sigmoid volvulus. And how do we differentiate sigmoid volvulus from cecal volvulus? Cecal volvulus, remember, this will show you a single loop with presence of hostrations, giving an embryo-like appearance on the abdominal radiograph. You see a coffee bean extending from right iliac fossa to the left upper quadrant. And you will see the hostrations. And in front of the cecum, what do we have? The small bowel. So it will be associated with small bowel obstruction. Commonly seen in young females who are having some pelvic surgery done, hysterectomies or pregnancies. So when you have young female with history of pelvic surgeries, pregnancies, showing this kind of embryo-like appearance or hostrations are present, single loops are seen on the abdominal radiograph, also with small bowel obstruction, this is suggestive of cecal volvulus. So remember to differentiate gastric volvulus, sigmoid volvulus and cecal volvulus. And when we have a hollow viscous perforation or pneumoperitoneum, what are the radiological signs? This is important for your exam. So for pneumoperitoneum or hollow viscous perforation, we all know you will see air under the right hemidiaphragm. You will also see air under central tendon of the diaphragm. This air under central tendon of the diaphragm, this is called as cupola sign. There is a distended abdomen. This is football sign. There is air on either side of the bowel wall. This is Wriggler's sign. There may be triangular air pockets called as telltale triangle sign. Between the bowel loops or between the bowel loop and abdominal wall, you see triangular air pockets, that is called telltale triangle sign. So a triangular air pocket tells you that it is not a luminal air. None of the bowel loop is triangular in shape. So when you see triangular air pocket, it is not a luminal air, it is a extraluminal air. This is suggestive of hollow viscous perforation, telltale triangle sign. And Morrison's free gas is, imagine between the liver and the kidney, you are having air collected. That is, in the Morrison's pouch, you have a free gas. This appears like a cap called as Doge's cap, Doge's cap sign. So Doge's cap sign is Morrison's free gas, also seen in case of hollow viscous perforation or pneumoperitoneum. You will see the lateral umbilical ligaments. There is a median umbilical ligament called as urachus. And the falciform ligament around the liver. So all the ligaments stand out, the falciform ligament, the urachus, the lateral umbilical ligaments, all of this is suggestive of pneumoperitoneum or hollow viscous perforation. Pneumoperitoneum or hollow viscous perforation. Here you can see air anterior to the liver. This is again pneumoperitoneum. And in pneumoperitoneum, you will see air on either side of the bowel wall. This is called as Rickler's sign. And such triangular air pockets between the bowel loop and the abdominal wall, or between the bowel loops, or between the abdominal wall and the bowel loops, all of this is telltale triangle sign. All of these are signs of hollow viscous perforation or pneumoperitoneum. And what is this abdominal radiograph showing? In this abdominal radiograph, you can see that the central loops are dilated and they give a step ladder appearance, one above the other. So it's a small bowel obstruction. And which small bowel? Is it jejunum or ileum that is obstructed? If you see the radiograph carefully, you can see this mucosal folds running through and through the bowel wall. These are called as plica circularis or volvulae conjuventis. And because of the presence of plica circularis or volvulae conjuventis, we are calling this jejunal obstruction. So this is jejunal obstruction. So we should know what are the features of small bowel obstruction and large bowel obstruction. The small bowel obstruction shows you a step ladder pattern, a string of bead appearance, and the plica circularis or volvulae conjuventis, these are jejunal obstruction. And you also see solid feces sign. So remember, all this as they are seen with small bowel obstruction. So step ladder pattern, string of bead appearance, and solid feces sign, all of these are small bowel obstruction. Now look at this abdominal radiograph. You can see peripherally placed bowel loops. These peripherally placed bowel loops with haustration, this is large bowel obstruction. And what is the difference between a mechanical obstruction and a functional ileus when you have? Remember, if there is rectal air present, if rectal air is present, this is suggestive of functional ileus. Functional ileus, right? So if you see peripherally dilated loops with the presence of haustration and rectal air is present, this is functional ileus, large bowel obstruction. And what is this abdominal radiograph showing? I hope you can see this is a rectal foreign body. Rectum is a common site for foreign bodies, right? In psychiatric patients or due for sexual pressures, people have different types of foreign bodies impacted in the rectum. So this is a rectal foreign body. And what is this image showing you? On this image, you can see there is a metal button kept at the anal dimple, and you are seeing the rectal air. So when you measure the distance between rectal air and the metal button with the child in an inverted position, an upside down position, this is called as invertogram. Invertogram. And remember, invertogram should not be done immediately after birth. You need to wait for the gas to reach till the rectum. So this is done 24 hours after birth. An invertogram, please remember, if you have the distance between the metal button and the rectal air, this is suggestive of high anal atresia. And for this, a abdominal approach is preferred. And if the distance is less than 2 centimeters, this is low anal atresia. And for this, perineal approach is preferred. So if there is distance between the rectal air and the metal button more than 2 centimeters, that is high anal atresia. For that, you go for an abdominal approach. And the distance between rectal air and the metal button is less than 2 centimeters, that is a low anal atresia, and that is a perineal approach is better to repair it. And this invertogram that is done 24 hours after birth is to evaluate whether it is a high anal atresia or a low anal atresia, right? So, to evaluate a case of imperforate anus or anal atresia, you do this for imperforate anus or anal atresia. Right? And where you see this thumb sign, where you see mucosal thickening giving thumb-like filling defects. So, thumb sign or thumbprint sign, especially at the splenic flexure of the colon, this is a watershed area of colon. So, whenever we have ischemic colitis, the mucosal thickening will give you this thumbprint sign. This is feature of ischemic colitis. Can be seen with other colitis also, but classically you study this with ischemic colitis, thumbprint sign, especially mucosal thickening at the splenic flexure, the watershed area of the colon. And where do you see such corkscrew appearance of duodenum, where all the small bowel loops come to the right of the vertebral body. If this is the vertebra, all the small bowel loops come to the right of the vertebra. This is what is corkscrew appearance of duodenum. This is seen with non-rotation or midgut volvulus. And this non-rotational midgut volvulus also shows you whirlpool sign, where the small bowel loops twist around the supramesenteric artery. So, this whirlpool sign is seen in non-rotation or midgut volvulus. Corkscrew appearance of the duodenum is midgut volvulus or non-rotation, whereas corkscrew appearance of the esophagus is diffuse esophageal spasm. And where do you see a cobblestone appearance on the barium study? Cobblestone appearance you must have studied. Because of the fissures and fistulas in between and the skip lesions, you get a cobblestone appearance in Crohn's disease. What is the other finding that you see? In Crohn's disease, you will see there is, in Crohn's disease, also remember the presence of this prominent vasa recta called as the comb sign. And the mesenteric fat will come and lie very close to the bowel, that is called as creeping fat sign. So, creeping fat sign and comb sign are also a feature of Crohn's disease. You can remember all this, Crohn's disease. Now, what are the findings that you have in Crohn's disease? You have string sign of Cantor, skip lesions, transmural inflammation, because the transmural inflammation and the creeping fat around it on a short axis, it will give you this target-like appearance. Fissures, fistulas, rose thorning, bowel perforation, also increased incidence in Crohn's disease patients. Pseudosaculations, because of the fibrosis of the gut, there will be outpoachings called as pseudosaculations. Creeping fat sign, comb sign, the cobblestone appearance, all of these are radiological findings that you see with Crohn's disease. And this image is a string sign of contour, string sign of contour. And what are the radiological findings that you see in ulcerative colitis? In ulcerative colitis, remember there is presence of this ahostral bowel loop called as lead pipe appearance. The earliest manifestation in ulcerative colitis is the presence of mucosal granularity. And you'll have ulcers, superficial ulcers involving the mucosa and submucosa. So, not involving the muscle layer, only involving the mucosa and submucosa. These are called as buttonhole ulcers. And there is superficial involvement. All of this is what is ulcerative colitis, ulcerative colitis. Now, let's understand what are the radiological findings that we see with ileocecal TB. Now, ileocecal TB, you see a pulled up cecum. There will be widening of ileocecal angle. There is thickening of ileocecal walls. This thickening of ileocecal walls is called as Fleschner's sign or inverted umbrella sign. And because of the pulled up cecum, the widening of ileocecal angle and narrow terminal ileum, all of this gives appearance of a gooseneck deformity. And the column of the barium also does not stay at the affected area. It will be in the normal bowel but will be thrown out fastly from the affected area because it's an irritated bowel, so it will flush off the barium much faster. This is called a Sterlin sign. So, rapid emptying of barium from the affected area, this is called a Sterlin sign. So, basically normally the ileocecal region has an angle of 90 degrees. This is normal. But when you have ileocecal TB, there is mesenteric lymphadenopathy, fibrosis, all of that happening, the cecum is pulled up. There is thickening of ileocecal walls, narrow terminal ileum. And so, this is the normal bowel, the ileum, this is the narrow terminal ileum. So, this widening of ileocecal angle, pulled up cecum, the Fleshner sign, the gooseneck deformity that you have, all of these are signs of ileocecal tuberculosis, ileocecal TB. And remember TB, you have transverse ulcers. In TB, we have transverse ulcers. And because of these transverse ulcers and the fibrosis developing, you develop napkin ring stenosis in case of TB. So, remember there are transverse ulcers that develop in TB, and typhoid would have had longitudinal ulcers. Typhoid shows you longitudinal ulcers in the bowel, whereas TB shows you transverse ulcers, typhoid shows you longitudinal ulcers. Now, look at this image. Here in the large bowel, you see a column of barium passing like thin lines between the inflamed bowel. So, this column of barium passing as thin lines between the inflamed bowel, this is called as accordion sign. This is suggestive of pseudomembranous colitis. Pseudomembranous colitis. So, this is accordion sign. So, thin column of barium going between the bowel loops. This is accordion sign, picture of pseudomembranous colitis. And if you see these outpouchings involving the mesenteric end of the bowel, so where the vasa recta enter, that area is the weak area of the bowel, and whenever bowel peristalsis happens through this areas, you can see these outpouchings. This is called a sawtooth appearance, and sawtooth appearance on the barium study, this is suggestive of diverticulosis. Diverticulosis. And where do you see a apple core appearance of the bowel? Such apple core appearance of the bowel, this is CA colon, right? And where do you see a meniscus sign on the abdominal X-ray, a coiled spring sign on barium, a pincer sign or claw sign also on the barium study, and a target sign or a donut sign or a pseudo kidney appearance on ultrasound. And this is a CT scan showing one bubble going into another bubble. What is all of this? This is intersusception. So, what are the radiological findings of intersusception? Intersusception on X-ray shows you meniscus sign. So, when one bubble has gone into another bubble, right, so you see the area of air, this appears like a meniscus. The same thing on a barium study is appearing like pincer or claw sign. And this, when this intersusception is reducible, when you are able to have the column of barium gone between the bowel loops, you get what is called as coiled spring sign. And coiled spring sign is a sign of reducibility. It's a sign of reducibility. It's a good prognostic finding. So, when you are able to see the column of barium going between the bowel loops, giving a coiled spring-like appearance, that means it's a reducible intersusception. That's a sign of reducibility. And intersusception on ultrasound shows you the target sign, the donut sign, because one bowel loop going to the other bowel. When you see a short axis view, you see the mucosa, bowel wall, mucosa and the bowel wall giving a target sign or a appearance of a donut. And on the longitudinal scan, it gives a pseudo kidney appearance on ultrasound. Pseudo kidney appearance on ultrasound. So, all of these pseudo kidney appearance, this is on longitudinal ultrasound. You see the mucosa and the edematous wall of the bowel giving a pseudo kidney appearance. So, donut appearance, target appearance, these are on the transverse axis ultrasound. whereas a longitudinal view of the intersusception gives a pseudo-kidney-like appearance. All of these are important findings that you see in intersusception. So these were some important radiological aspects with GI radiology important for your exams.